Welcome back once again. Now we would like to proceed with session 2 of track 1. I would like to first welcome our moderator for the session, Dr. Amr Noor. He's a consultant psychiatrist and clinical academic lead of the forensics department at Mossley, UAE.
Good afternoon, everybody. Thank you very much, Dr. Fatma. Our next lecture will be what can liaison psychiatry do in, and this will be presented by Professor George Tadros from the UK. Professor Tadros is a consultant in old age and liaison psychiatry in Birmingham, UK. He's a professor of psychiatry and dementia at Aston Medical School at Aston University in the UK. He's also an adjunct professor of psychiatry at Faculty of Medicine, Cairo University. Over to you, Dr. Tadros.
I am delighted to be among you today to talk about two important issues. One, as all of you know, is COVID and what is happening around us, and also the role of liaison psychiatry and what psychiatrists who are working in acute hospitals can offer to patients, to the hospital management, and to the whole country. During my talk, which should not last for more than 40 minutes, I will cover the effect of social isolation on patients in general, but particularly in older people. As you know, I'm interested in this area. We'll cover other issues like the high risk of infection, what comorbidity could do to psychiatric and physical presentations, increased mortality, not just because of COVID, but because of issues related to COVID, such as social isolation and medication. Certainly we'll cover the effect of medication. I will spend some time talking about COVID delirium and how can we deal with that. I will not forget to talk about dementia and how patients with dementia could be helped during this situation. At the end of my presentation, I hope will answer the title of my presentation. The question is, what can liaison psychiatry offer at the time of COVID? By now, you must have heard that the UK is going through the second wave and the second period of complete lockdown. And as happening in Emirates, older people, especially above the age of 65 or 70, finds it more complying that they have to stay at home. Obviously, there are two ways to look at this. One way to think that we are protecting them, it is to avoid all the complications of older people having COVID, but also, if you are cynical, as I could be sometimes, we are trying to prevent older people from putting overburden on the system, preventing them from having illness, requiring help, requiring ICU, so they could also be seen as a burden or pressure on the system. Self-isolation for anybody is not good. However, for older people, it can increase the risk of depression and anxiety. We'll talk about that in more details. Even accessing daily needs like shopping for younger people, that's much easier than older people, especially if we start relying more on technology, online ordering, online shopping. Younger people will be able to do that far easier than older people will find it a challenge. Meeting family members online is becoming a common thing, but for older people, it's not the same. Dealing with technology, dealing with emotions. So you can see older people will be disproportionately disadvantaged in dealing with technology and COVID restriction. That will lead to difficulty in compliance with time. Let me share with you this American study, which is very interesting. They managed to get data from the National Social Life, Health and Aging Project. they gathered data for over 3,000 people between the age of 57 and 85. Obviously, it's a wide range, and I can tell you the age of 57 is really young. However, this is what they did. And they looked into social disconnectedness, and they measured it with social perception, self-perception of social isolation. And they found that social disconnectedness has higher prediction for perceived isolation. The more there is disconnection around the older people and younger people, the more they have perceived isolation. But the interesting thing is, the more they have perceived isolation, the more prediction for higher level of depression and anxiety. So you can see that the social network structure and support is strongly wired with our sense of well-being, and any erosion of our social network connectiveness that leads to higher level of depression and anxiety, which you will see have other effects on our life. Let me pick your brains regarding this very interesting study from Cyprus, which is not very far from my own home city, Alexandria. And what it shows, which is a warning for all of us, that the social isolation during the time of COVID can increase the risk of death for older people for issues not related to COVID. So what they found that loneliness and isolation will increase the risk of developing coronary heart disease, heart attacks, strokes, and that is independent from the traditional cardiovascular risk disease. And what they have estimated, which is very worrying, that for every 3 months of social isolation, Cyprus will have extra 200 deaths that would not have happened if there is no social isolation. So in the year, Cyprus would experience 1,200 extra deaths that would not have happened if social isolation wasn't there. If I think about my own country, which has 100 million people, so that is 100 times more than the figure in Cyprus. If you think of United Arab Emirates, which has roughly 10 million people, that means 10 times more than the figures they found in Cyprus. That is worrying indeed. And just to take you back to something all of us have known about variation, seasonal variation in suicide. And this is from my own study in Birmingham, UK. When we were much younger, we learned that suicide varies with seasons, with peak in spring and autumn. And then with time, we learned that that is not true. And recently, with all the global warming, internet connections, the effect of seasons disappeared. And as you see now, this slide in front of you shows no difference in rate of suicide in the different seasons in Birmingham, only if you look at all the ages. But if we examine the records again, this is the data from Birmingham, and the splitting into older people and younger people, you'll find no difference between seasons in younger people. But in older people, there is a significant difference with the p-value equal 0.002, that the summer season has more suicide cases than the other seasons. The point here is the summer season is better weather in the UK, but the reason for that increased suicide in older people in the summer season is the breakdown of the social network connection around them. The GP is away on a holiday, the psychiatrist away, the social services not working, the nice friendly neighbors are not around, the family are busy with their holidays, and the older people suffer with lack of connection, breakdown of their social network, and suicide happens. I'm just trying to make the same point again. Social disconnection will have higher impact on the well-being of older people, obviously in a negative way. We have just started hearing and reading new reports and studies about the neuropsychiatric manifestations of COVID. In the first part, the focus was on physical manifestations and obviously things like loss of smell and inflammatory process. But in the SARS outbreak, which you would remember how it happened, and you would know that SARS is within the same family like COVID virus, 50%, roughly 50% of people suffered with post-traumatic stress disorder. Around 40% had depression. Panic disorders happened in about 35%, and even OCD in about 15%. But if you go back to the recent studies with COVID, roughly around 20% of people developed neuropsychiatric manifestations. Most of it was anxiety, mood disorders, and suicidal ideations. Other things like headache and encephalopathy was also reported. I would like us to think about what happens in a highly populated country like Egypt, what would be the percentage. Again, being in Emirates, I would like you to start thinking, what's the percentage of people in UAE who had COVID and then developed neuropsychiatric disorders? You would certainly remember this man. As I'm recording this, I'm not sure whether he's still the president of the United States of America or not. I'm sure you can tell me. He was shouting and saying, "We have found a cure, hydroxychloroquine, and you must give it to patients." Obviously, as you know, it's given for malaria, rheumatoid arthritis. But I want you to think, if patients are treated with this medication, the side effects include mood changes, depression, anxiety, psychosis even, psychomotor agitation, and confusion. So working in acute hospital, when you find patients on treatment developing these kind of symptoms, just ask yourself, what are they on? And whether this is the reason for neuropsychiatric manifestations. Another story of success which happened in Britain, actually, my hospital where I used to work was part of the clinical trial. And they found dexamethasone is helpful in reducing death in coronavirus. But just we need to read the data right. It reduces death in people who are in ICU, not in other cases. But again, with dexamethasone, what happens? Psychosis, I'm sure you know that even better than me, depression or mania, sleep disorder, severe anxiety, and patients with dementia will have more profound cognitive impairment. So again, be careful with that. Another proposed medication is azithromycin, and that really worried me because my friends in Egypt tell me they are just prescribing it willingly to anybody who suspected to have COVID or any symptoms, which might have effect. We are not sure yet, but what we are sure about, it has significant side effects. You see the list of side effects in front of you, but I'll just pick up few things like agitation, anxiety, like hyperactive behavior, like irritability, nervousness. All these kind of things can actually make the patients worse. So again, it's not just the COVID that can affect our patients or the COVID neuropsychiatric manifestations, but also the treatment that is offered to them. And this is where liaison psychiatrists or psychiatrists working in acute hospitals or in multi-centers can be very helpful. Next important topic I would really like to touch in with you is delirium. Let me speak first about delirium in general, and then I will have a specific time to talk about COVID delirium. As you all know, delirium is an acute confusion state. It fluctuates, it has a physical reason, but it's very important. And psychiatrists have an essential role to manage patients with delirium in acute hospitals. Just think about the hospital where you work. See how many older people there. And about 30 to 50% of older people who are inpatients will have delirium at any point. If you look at the ICU, about 80% of patients in the ICU will have delirium. And the patients with dementia, half of them at any point of time in the acute hospital will have delirium. The problem is delirium is underdiagnosed, not treated properly, can lead to mortality, can lead to behavior disturbance, and lots of complications, even falls and infection. And there are two types of delirium. There is hyperactive delirium, which most people try to treat, but also there is hypoactive delirium when the patient is very quiet. And medical and nursing staff tend to ignore them because they are very quiet. But actually mortality is higher in the quiet one, the hypoactive delirium, rather than in the hyperactive delirium. I am now sharing with you the easiest and the most effective scale in diagnosing delirium, which is called 4AT scale. And it has 4 sections, hence the name. First one is about alertness. When I walk to the ward and find patients who are sleeping in the morning or cannot open their eyes in the afternoon, I have to think of delirium. And then the AMT4, which is only 4 questions: age, date of birth, where they are, and the current year. And I'm very attached to this 4MT because that was developed in the hospital where I work. And then attention, and then the last one, whether the onset was acute or not. You see, if the patient scores 4 or above, that's possible delirium plus or minus cognitive impairment. 1 to 3, possible cognitive impairment as well as the delirium. 0, that's delirium or severe cognitive impairment. And this is an easy scale you can use. And in the next slides, I will show you a little bit more about it. So this is the 4AT scale in English, and you have the way how you can score it. Very easy, very simple. Shouldn't take more than 2 minutes of your time. And guess what? It is also available in Arabic. You can get your junior doctors, your nurses. You can train the nurses on the wards to do it frequently with the patients, and then you can look at the score. Very easily done, very helpful. I'm sure I'm talking with very clever and caring psychiatrists who are only psychiatrists, but also they are doctors. This is why when you see a patient with delirium, you have to think of full and complete assessment, physical and psychiatric. There are points that we tend to forget. One is sensory impairment, hearing and seeing, which are very important because the privation of hearing or seeing can increase delirium and behavior problems. Don't forget to look into the joints in case there is arthritis, gout, pain. That is a very common reason. Mobilize the patient, see how they walk. Look into their back if there's pressure, sores or bruises or anything that needs attention. Don't just look at the patient from the end of the bed, but remove the cover and have a good look at them. ECG is important. Urine test rather than the dipstick are very important. Be aware of any surgical problems like strangulated hernia or abscesses or anything like that. Investigations, obviously full blood count, trying to find the reason. But in the time of COVID, oximeter, auto saturation, respiratory rate are very important. I wouldn't, as I said, rely on urine dipstick. You need a full urine analysis, MSU. Again, try not to exhaust the patient with too many investigations like CT scan unless it is indicated. Treating delirium is mainly about treating the cause, which is your physicians working alongside you should take care of. But obviously, as a doctor, you need to look into the whole care management and what's happening. If you ask me about the best way to calm patients in a stage of delirium, if you ask me a few years ago, I would say benzodiazepines. Now I'm saying no. We have evidence that benzodiazepine can prolong the period of confusion and can increase mortality and falls. So what is recommended now is a small dose of haloperidol or a small dose of risperidone. That would be about the best way of managing behavior problems. Later, I will show you a whole toolkit how you manage behavior problems in delirium. But you know what is better than managing delirium? It is preventing it. And again, I will give you later the toolkit about the prevention. But preventing delirium will lead to less work, better management, less death, less time in the hospital, less complications, and certainly it is the best way to care for patients is to avoid delirium. In the next slides, I'm going to share with you the best available evidence, the good practice guide for COVID delirium or managing patients with delirium in the COVID time. As you see, it has been done as a collaborative work between the Royal College of Psychiatrists and the British Geriatric Association, and I'm sure you'll find it helpful. COVID delirium is not very different in the pathology from delirium itself, and the clinical expression of encephalopathy is part of the context. Symptoms presenting will cause challenge, especially behavioral problems on the wards or in nursing homes or at home, on home, will cause a real challenge to the family, the staff, the doctors, everyone. There's also extra challenge that comes from what happens at COVID. We previously spoke about the medication and its effect, but also the interesting thing is, because of the restricted environment, now in hospitals, you are very restricted to use non-pharmacological treatment, which is always the preferred option. So this is now out of the window. You can't use it, you can't have group therapy, you can't do orientation, you can't do many of these non-pharmacological. On top of that, the restricted environment, as explained earlier on, puts extra burden on the brain, extra burden on the behavior, on the feeling, depression and anxiety, paranoia, all these kind of things. So when you're managing a patient with delirium, COVID delirium, you are managing them like the usual delirium with extra restrictions. You will not find it easy to find non-pharmacological therapy. You'll find the environment working against you and the usual medication the patient is on because of the COVID also working against you. This is why I hope the next few slides will be useful. People try to find and explain the reasons of increasing delirium at COVID situations, and there are many theories or many pathways. One is the direct central nervous system invasion by the virus, so it becomes part of the engagement with the virus. Parallel to that, you will find CNS inflammatory mediators, which we know that takes part in delirium and perhaps the dementia too. At the same time, you might find other organs in the body are failing, and that leading to more delirious effect, like respiratory failure or kidney failure. Effect of sedative drugs, as we spoke earlier on, prolonged mechanical ventilation, prolonged ICU admission, That all significant factors. Other factors like immobilization and unfortunate environment that's working against you can also lead and contribute to the delirium presentation. As you can see below, these are the medications recommended by the group of the Royal College of Psychiatrists and British Geriatric Society in the management of COVID delirium. First one is haloperidol, small dose, 0.5 milligram, maximum 2 milligram, but be careful about QTC interval. You have to do ECG, think of any Parkinsonian features, think of any negative effect on delirium. Risperidone, the same thing, a quarter of a milligram, half a milligram, maximum 1 milligram, but be careful about patients with dementia of Lewy body. They could get worse with antipsychotics. After all of this, if you really have to use lorazepam, you can on a small dose, but be aware that it could have impact on renal functions and it could increase the period of confusion. I tried for you to find a way that you could remember the guidelines for the management of COVID delirium in acute hospitals. So I made up the word scrubs for you because it's very interesting. As psychiatrists, we don't even now wear the white coat. And I have been wearing scrubs in the hospital as a psychiatrist, which is very interesting. So just remember scrubs in the time of COVID. The S for screening for delirium using the 4AT as I showed you. C for curb the risk of delirium. That's the prevention. Regular orientation to the patient. Avoid common things like UTI or constipation. Very simple way, treat pain. Paracetamol is very good and effective pain management strategy for older people. Please don't use tramadol or strong painkillers. They'll make things worse. Look at any supra-added infection, good oxygenation, and avoid polypharmacy. So this is the C, curb the risk. R, reassure the patient that they're having delirium, which should pass. Reassure the family and give them explanation. If you want to give the family some information, go to the SIGN website and they put the address for you. For your staff, use unified approach. Train all the staff to approach the patients in the same way, not everyone to have a different strategy. Also look after your staff. B for behavior management. I will share with you in a minute the BPSD toolkit, which should help in managing behavior problems. And then sedation, as we talked before, haloperidol or risperidone rather than benzodiazepines. Scrub, screen, curb the risk, reassure the patient and the staff, unified approach with all your staff, behavior management, and sedation. If your patient develops behavior problems as part of delirium in the acute hospital, as a liaison psychiatry team, you can use the toolkit, which has 3 stages. The toolkit, again, was a collaborative work between the Royal College of Psychiatrists, the Royal College of GPs, and the Department of Health, as well as Alzheimer's Society and other organizations. As you see, the toolkit has 3 colors. Green for prevention, amber when you watch what is happening but don't interfere, and red when you have to interfere. The green phase is about prevention, so this is about orientating the patient, avoid dehydration, manage the pain, avoid constipation, manage the depression, put them in the right treatment for dementia, and also have a person-centered care approach to all the patients. Environment is very important, with stimulation, with light, with orientation board, but as I mentioned before, in the COVID time, you might find all of this difficult. Therefore, you might find yourself moving from the green phase of prevention into the amber phase of watchful waiting. Patients will develop behavior problems, but that does not mean automatically we have to intervene with medications. You could just watch, give them a little bit of space till they settle. If the behavior problem is not causing them or other people any danger, you can tolerate it. The nurses can reassure them. They can use life story, get albums to look at their life story, good sleep hygiene, some hand massage using lavender oil, all these kind of things without reverting to medication to see whether the behavior will settle down or not. If the behavior settles down, you don't need any medication, and that is a well done job. If the behavior does not settle down, you might revert to medications to help the patient. You can use a small dose of antipsychotics like risperidone, which is licensed but can increase risk of strokes and heart attacks. But if the problem is sleep, you can use some hypnotics. If it is pain, you treat the pain. If it is an anxiety, I can use something like Lyrica small dose, which I know you might have some problems with that. But try to choose to treat the reason of the behavior problem in the safest way. Now I would like you to look at this flow chart, how the toolkit works. So patient comes in who are not on antipsychotics, you do the prevention, you hope nothing will develop as behavior problems, and that will be good luck. Or they have developed behavior problems, and then you go for watchful waiting. If it settles and become green, that's good. If it goes red, then use the medication in the way we explained. But if your patient comes to the hospital already on antipsychotics, then you follow these different flow charts where you try to reduce the antipsychotic if possible and try to turn them from red to amber or green. It will be a very well done job if people leave the hospital on no antipsychotics and with no behavior problems, or even with less antipsychotics and no behavior problems. You will do a great job by achieving that. You might know that in Birmingham I led a new model of liaison psychiatry called Rapid Assessment and Interface Discharge, which showed great benefit. I'm not going to talk much about it because I have published that before, but I'm going to show you some of the benefits in a very brief way. In our liaison team, in a medium-sized hospital, we'll have 2 consultants, 10 nurses working all around the hours. We'll have junior doctors in training, SHOs and registrars. We used to have psychologists as well. And then we have a very high response rate. We'll respond to any referrals from the emergency within an hour. But if patient comes to the ward, we'll respond within 24 hours. And you can see in the graph here, we get nowadays, every month, we get about 400 referrals every month in a medium-sized hospital. 1/3 of them for self-harm, 20% for depression, delirium, dementia, confusion, another 20%, about 10% for confusion, and about another 3%.
Welcome back. Our next lecture will be on opioid analgesia dependence, the story and beyond. This will be presented by Dr. Yasser Abbasi, mostly in the UAE. Dr. Yasser Abbasi is currently the lead of the Addiction Clinical Academic Group for Maudsley Health at Al Amal Psychiatric Hospital. Prior to that, Dr. Abbasi was the clinical director of the addiction services at Mercy Care NHS Foundation Trust in the UK. During the span of almost a decade of being a consultant psychiatrist, Dr. Abbasi has contributed to the development of addiction services in the UK, contributed towards academia, increased awareness about mental health and addiction, set up a charity, and passionately supported various causes. Dr. Abbasi presented his NHS trust and the charity he works for during the British Parliament All Parties Parliamentary Group for Prescribed Drug Dependence meetings, supporting the need to increase and improve services for those who suffered from this illness. Dr. Abbasi is a member of the Transcultural Psychiatry Special Interest Group at the Royal College of Psychiatrists and has increased awareness regarding mental health within South Asia. Please welcome Dr. Yasser Abbasi.
Hello, everybody. For those of you who don't know me, my name is Dr. Yasser Abbasi. I'm a consultant psychiatrist at Maudsley Health and the lead for addiction services, delivering services at Al-Aman Psychiatry Hospital in Dubai. I'm also an adjunct clinical associate professor at Mohammed bin Rashid University of Medicine and Health Sciences in the UAE. I'm affiliated with the Royal College of Psychiatrists, being the overseas doctor's representative for the Transcultural Special Interest Psychiatry Group over there. And I've also set up a charity in the UK called PAIN, which talks about painkiller addiction. And very nicely leading on to the topic that I'm going to discuss today with you is addiction to medicines, but really talking about addiction to opioid painkillers and whether there's any reality in it or not, or whether it is a problem that we're facing here across the world. So as we go along our slides, there's no declaration of interest in the past 12 months. Prior to that, there have been some declaration of interest, but not in the past 12 months. This is the details of the charity that I've set up. It's called Pain Charity UK, and it's Painkiller Addiction Information Network. It was set up with Catherine Kemp, who is the founding member with myself, who became addicted to painkiller because of some underlying organic problems. And then we set this charity up. It was one of its kind in the UK and then in Europe as well, which was looking into painkiller addiction. As we go along, we try and figure out what the issue is related to painkiller addiction. As you would see, a lot of information on the news. So this news item suggests this new bleak record of 71,000 Americans who are dying from drug overdose in 1 year. Now, particularly around this COVID pandemic, which it suggests that it's become worse. People are trying to find painkillers because they can't go to the doctors from illegal sources. And when they're going to illegal sources, they end up buying things like synthetic fentanyl, which makes things worse. Opiate overdoses were skyrocketing as well before COVID, but COVID-19 made it even worse. As the news item highlights, the pandemic is creating such conditions of social isolation. As there's no job, there's despair, people don't know what to do, they're addicted to opioid painkillers and they're taking more, and without realizing that it can actually kill them. Even in the UK, there were issues related to UK opioid painkiller addiction over there, and the fact that there weren't specific services. And there's an emphasis on the fact that we need specific services dealing with opioid painkiller addiction. Mainstream services, to some extent, can deal with the problems that opioid painkiller addiction poses with, but other evidence and anecdotal views do suggest that you do need some specificity in the service that you're providing for opioid painkiller, which then sets it apart from the mainstream addiction service. So this review looked into what types of services were available for opioid painkiller addicts in the United Kingdom, and it was based on a Public Health England review and suggested there was a severe lack. I was interviewed for this as well, and I very clearly suggested that I feel that this is a hidden epidemic which we haven't really truly properly discovered. And we feel the number of people suffering from this will be running into millions, if not hundreds of thousands. And those experiencing addiction to opioids end up in primary care setting or private setting, not properly being dealt with a holistic approach. Again, you see examples of not only those taking painkillers, but those prescribing painkillers are at risk, because painkiller addiction can truly affect your cognitive ability to reason and make you do things which you wouldn't do in the most usual circumstances. Therefore, this news article suggests that a GP was actually attacked by someone asking for his pain relief medication. How do we get to this point? How do we get to this situation? So if you go back some time, you see things marketed by pharmaceutical companies on occasions are not completely what they seem like. For example, some time back, this was being advertised as Mother's Little Helpers. You'd be surprised to know what this medication is. It says on the side. But this was diazepam, Valium. And it suggested that after a busy day at home, making dinner, looking after the children, a stereotypical housewife, in the end, to just relax, you take 8 tablets of diazepam just to kind of relax. And see how that narrative has changed over a period of years. So what we know now about medication or pharmaceutical products might be different to how we know it years later. And hence we need to be very much aware of what this medication can do, or what these medications can do or are capable of doing, particularly opioid painkillers. You see, glycoheroin was marketed as a relief for cough. It was a cough medication and highly marketed as such. And Bayer and Company, right at the beginning in the 1800s, was marketing heroin as something which was useful for cough as well. And it's not that it doesn't. It does help. It does help, but that the risks and the dangers of taking such things are much higher than the benefits of it. So this is a paper published in 2013 by myself and my co-authors, and this looked at a number of people attending a substance misuse service, a total of 1,537 people, and to see how many of them were already prescribed medication even before they came to mental health services or addiction services to be diagnosed with something. So almost half, or more than half, 56% or more, people attending the services were taking prescribed antidepressants and anxiolytic without actually being diagnosed properly with depression or anxiety. This then opens up the door for misuse and abuse, really. This was another paper I published with my co-authors in 2017. And this looked at what types of service would meet the needs of patients with opioid analgesic dependence, OAD. And opioid analgesic dependence is a growing concern, and how do we, and what kind of model can we use to help? But now we take a step back, trying to understand what opioid analgesic dependence is. What does it look like, and what is the problem that we see? How do we treat opioid analgesic dependence? You've got pain specialists prescribing painkillers, you've got primary care physicians prescribing pain medication, you've got addiction specialists also prescribing things like methadone and buprenorphine, or these patients coming to the addiction services for care, for treatment. How do we treat them? Who treats them? Which is the best setting? And the answer is none of them. It is best treated together in an integrated fashion. So if you work together and you manage the pain in a way which is away from addictive medication, you liaise closely with the primary physician and the addiction specialists help them come off the addictive substances, then the outcomes will be better. But how does opioid analgesic dependence compare to other chronic illnesses? You'd see that it's almost the same, if not more chronic. So you see asthma and diabetes, there's 40% concordance or 60% concordance with treatment and medication. In opioid analgesic dependence, it's almost the same. Typically, there's 40 to 60% relapse within 1 year of discharge. And hence, it is a chronic relapsing and remitting illness. And one should treat it as such. One should not think that you are coming in for treatment, and as soon as you come in for treatment, suddenly you're treated. Suddenly, with a prescription of a tablet, the opioid analgesic dependence disappears. If you look at the effects of opioids within the brain, and this is just opioid, it doesn't matter whether it's diamorphine, heroin, fentanyl, codeine, tramadol, or any other opioid. It kind of has the similar kind of function on the brain. So if you use opioids frequently and persistently, the euphoria induces certain functional changes in the reward center. And this leads to a biogenetic vulnerability in the individual. Naturally, dependence and withdrawal can occur in long-term use, but also the fact that opioid dependence can result in some same neurobiological changes as other opioids, like illicit opioids. So you can see in a normal brain, the uptake of opioid and the PET scan images show changes in the brain function. The reduction in the red of opioid-dependent brain shows reduced dopamine binding. Over here, this is the normal brain, and you see on the left, the normal control, the dopamine binding to D2 receptors is relatively more as compared to the opiate-dependent brain. And hence they have less effect, and hence the reward pathway is compromised, thus making them vulnerable to continued use and continued addiction. So what is the scale of the problem here? How big is the problem, and should we really be worried? Is it just a small group of people doing it? Is it just 10 or 15 people doing it? Or is it a much wider problem? Do we overestimate the problem because it's in the media? Do we overemphasize the problem because the media is portraying it? Or is it really a big problem? So if you look at Europe, you'd see, if you look outside Europe, you'd see that it is becoming increasingly a problem. The global consumption of opioids, and I'm talking about prescribed opioids, is increasing by the day. So opioid analgesics were involved in about 43% of all overdose deaths in the US in 2010. That's 10 years ago. It has increased even further in the past 10 years, including 2020. Canadians are the second largest consumer of opioids per capita. So after the US, it's Canada, which is increasingly using opiate painkillers. It is becoming more and more of a problem in terms of abuse in Brazil and in Australia. The use of non-medical use of pharmaceutical opioids has doubled. Again, this is from 2010. If you look at 2020, this is increased further. And if you look at this paper published from the US data, this suggests the heroin use going down from the time that methadone was increased in the 1960s as a substitute program, and gradually over the years, it has been going down with a slight increase more recently after around 2010 onwards. But it's been at the lowest in early 2000s. But at the same time, the use of prescription opioids have been steadily increasing, with them actually overlapping in the early 1990s, where the heroin and the prescription opioid use is almost equal. But then it overtook the use of heroin. So now more people are using or prescribed opioid painkillers as compared to people using heroin. And there could be multiple reasons for that. But then it then gives you an avenue where there's more room for abuse, more room for misuse for these medications. If you look at the opioid consumption map, and you look at how much morphine is being consumed in terms of milligram per capita, you'll see the highest consumer that is 100 milligrams or more. No, in fact, more than 100 milligrams. You can see USA and Canada are quite high. And then Australia is almost the same, including the United and Western Europe. So Western Europe, the USA, Canada, Australia are the highest in the world. Some areas there's no data. In other areas you can see it's increasing. Within the Middle Eastern area, around Saudi Arabia and UAE, you see the consumption varies from between 1 to 5 milligrams per capita to 5 to 25 milligrams per capita. And again, this needs further studies to establish true prevalence. Access to opioids and equivalent doses, you can see United Kingdom in the UK is greater. It falls within the 100 milligrams per capita or more. 100 milligrams or more per capita. The UK falls within that domain. If we go further down the slides, if I'm able to get it through, there you go. So if you look at the statistics from the UAE, there's a very nice paper published by Al-Ghafari in 2017, which looked at the trends of different substances being used. So if you look at 2013 and the breakdown, you see almost more than 200 patients that were being reviewed. Out of them, more than 200 patients were using tramadol. And then if you look at other substances, benzodiazepine, Lyrica, these are all prescribed medication. Neurontin and Legaflex, which is carisoprodol. You can see use of prescribed drug is quite high, particularly prescribed opioids. Again, this is from 2015. The paper was published in 2017, but this table represents 2015. And then if you look further, this is 2016. You still see tramadol in the top 3. So even in the UAE, prescription opioid painkillers is quite high and people are seeking help. So this data is from an addiction center which admit patients to detox. So people coming in for treatment for addiction, a lot of them have opioid painkiller addiction. So right, we've kind of described who is best to treat it. We've also described what the scale of the problem is. We've kind of described why it is a problem. But if someone's taking tramadol quite regularly, why do you want to treat it? Let them take it. What is the problem? Is there a problem? And to look at how we address this or answer this question, you look at whether it's affecting one's individual functioning. And opioid analgesic dependence has very dramatic sometimes, and if not dramatic, has serious consequences, which has social, psychological, and physical impact. So physically, if you look at how it affects you, it varies with opioid to opioid. It can cause intoxication, overdose, or withdrawal. People in withdrawal might not be able to function properly, or when they're taking the medication and they're quite sedated, they can't handle machinery, they might end up in accidents, and car accidents might lead to death. The long-term effect of opioids can be endocrine changes. It reduces sex hormones, particularly testosterone in men. It can cause hyperalgesia, which means it makes you more sensitive to pain and makes your pain worse. There's reduced immunity and it affects your sleep as well, which then eventually leads up to mood instability, anxiety, and agitation, and depression as well. And when you're experiencing all this will lead up to social impact, which means you lose relationships, you lose employment, your marital and family relationships break down, and you have financial problems. And that kind of is a downward spiral of very clear addiction. So how do you see pain and addiction matching up in terms of the presentation and impact on the person? So you see, if you've got persistent pain, you've got sleep disturbance, you've got secondary physical problems, you've got depression and anxiety because you can't sleep properly, you've got increased stresses, you've got functional disability, and you've got sleep misuse, which means you're not sleeping properly. Addiction almost has similar effects, and hence they're synergistic. If you don't treat the pain, the individual will go and find more painkillers because they can't function. And they might become addicted. And when they do become addicted, then they can't function either. And if they have pain and they are addicted, then the function is gravely impacted. So it's very important for you to treat the addiction and the pain together. Because if one of them persists, then the individual function is very much compromised. So who would be vulnerable to develop opioid analgesic dependence, or who would be more prone to develop opioid analgesic dependence? If we prescribe tramadol or codeine or buprenorphine or any other opioid painkillers, tramadol to anyone, would they become an addict? The short answer is no. These tablets, these medications are very important. They play an important role in treating certain pathologies. But what is important is to understand the risk associated with those who can become an addict. And also what other thing is important is the fact that you need to make sure that they are reviewed on a regular basis. They are reviewed at a regular interval so that you identify the need for prescription. You constantly review the need for prescription. So those who have a family or personal history of dependence or drug misuse, those who have genetic predisposition, for example, if they have a family history of heroin use or alcohol abuse, those who have a certain psychological profile, for example, if they have comorbid anxiety and depression, they've had drug exposure in the past, and they're all at risk of developing opioid analgesic dependence. And if you see these risk factors, that doesn't mean you should stop prescribing them opioid painkillers. You should make sure you're reviewing them on a regular basis and keeping your ears and eyes open to the potential symptoms of addiction and dependence. But mental health problems and addiction have a high comorbidity. So you may encounter these 4 different types of patients who are misusing opioid analgesic dependence, or who have only opioid analgesic dependence, but are misusing opioid analgesia. So you'll have OAD patients with ongoing pain. So their pain wasn't really properly controlled. They have chronic pain, and they've developed addiction because it was ongoing and it was long term, and they did not try and manage it anyways otherwise. You might have OAD patients with resolved pain. So they had pain and then they took medication, the pain resolved, but they continued to take medication. It was never reviewed, never stopped. For example, I remember a female, white British female in my practice in England who had breast cancer and had breast surgery 5 years ago. And she was still taking morphine sulfate, tramadol, and oxycodone 5 years down the line. And she very clearly remembers that within a year or two, the pain had resolved, but she encountered some marital problems, and one day she took an extra dose of morphine sulfate and then realized, aha, this kind of helps me, and then kept on going back to the doctor with these phantom pains, but then realized that it was inhibiting her function further, and then came to us for treatment. For those of you who like to know what happened to her, well, she was treated successfully and came off these opioid analgesics. So the third type of patient you might have are those patients who are pain patients with really, really poorly managed pain. So you're not giving them enough painkillers, or they don't seek help properly for their pain, and they end up finding tablets from their own accord or start doctor shopping. And then the third ones are recreational users who seek prescription purely for diversion or misuse purposes. So continuum of behavior generally is you are a self-treater or an adherent to medication. From self-treater, you become a recreational user, and then you become a substance user. You start abusing the medication that's prescribed, or you keep on looking for medication for every sort of symptoms that you have. You call them chemical copers, that they need medication for everything. They don't want to try anything else, and they end up being substance abusers because they end up using it for regularly. But if you look at non-medical use of opioid, you'll see 59% of teenagers in the US were given these medications by a friend or family, which is quite concerning that your friend or family might have had this medication, but then they gave it to a teenage person between 17 and 19 years of age and then started misusing drugs later on. Or you have an estimate of addiction rates among patients with chronic non-cancer pain ranging from 0% to 50%. It's a wide range, really wide range, which is very difficult to understand, but yet understandable because it's so diverse, the population coming into pain relief medication. But the focus is on non-cancer pain. And actually, with illnesses, terminal illnesses like cancer, you need these medications. So if you look at the pathway to dependence, what happens is you prescribe the opioid analgesic for pain initially. Many people at this point are treated successfully and do not then progress further. But for those who keep on presenting with the problem, keep on asking for more medication, more is prescribed, they eventually lose tolerance and control and develop hyperalgesia as well. They think they need more medication. They eventually use so much and they become dependent on it. There's so much so that the doctor would prescribe. And then after that, they come to a point where they feel they can't prescribe anything else. The doctor stops prescribing, and you end up looking at other sources of addiction, of opioid painkillers. And they go to cheap alternatives like heroin, or they start buying opioid painkillers from drug dealers, or they start getting it from family and friends. It's quite complex progression. It's not set in its way and can vary in its presentation. And many treatment-seeking opioid-dependent patients first use illicit prescription drugs before obtaining opioids from illicit sources. So, I mean, we all need to prescribe opioid painkillers. And again, the purpose of this presentation is not really to put you off prescribing them. The important bit is you are able to, first of all, make a correct diagnosis, then prescribe relevant medication for pain, give the right doses, and give it, most importantly, give it for the right amount of time. Don't just give it open-ended. Don't just prescribe it without putting in a review date. If you're prescribing opioid painkillers, and any painkiller for that matter of fact, you should always then have an immediate review date. If you don't, then most probably you're doing something which might not fit in the best interest of the patient. So patient presents with chronic pain, what would you do? Well, you need to prescribe. You go through the WHO ladder of prescription, and if you end up on opioid painkillers, then you end up prescribing opioid painkillers, and they keep on coming back to you, and then you start prescribing them chronic opioid prescription. They develop tolerance and hyperalgesia. You give them higher doses, and they eventually develop addiction. And they're not really motivated because the pain has no improvement. So what could you have done here? Yeah, throughout the patient's treatment journey, what could you have done? Well, when you're prescribing opioid painkillers for the first time, give it a consideration and see, well, is this the only thing that I can prescribe, or is there something else that I can prescribe? So that's one point to start thinking. Once you've prescribed it, and there's chronic use and possibly development of tolerance and hyperalgesia, before you increase the dose further, think, do I really need to increase the dose further? Or is there something else? Is the patient experiencing hyperalgesia? Have you tried any other non-opioid medication? Is there anything else that can help the patient rather than me increasing the medication further? And even if you end up increasing the medication further, you then think, well, the person is dependent on what do I need to do? Do I review the dose? Do I stop prescribing? If you just suddenly stop prescribing, the patient goes into withdrawal and it's not a pleasant state, and they then end up seeking alternate sources. So the most important thing is you keep on engaging with the patient. So don't cut them off completely. Work with them, identify to them that it's a problem, and then gradually reduce. As long as you're reducing, you're going in the right direction. That's my motto. I always say to patients and other clinicians that I'm teaching and training, that if you are reducing, if you're tapering off, and if you are reducing the dose of what you're prescribing, even if it's over a period of weeks and months, fine, you're going in the right direction. So what would possibly suggest, what would be the red lights? So for example, if you feel somebody's coming to you and you want to be aware of what could be the things to watch in them, if they are misusing the prescribed opioids, these are the things. Savage SR calls them the 4 C's. And I also like using this in my individual practice. So if you look at adverse consequences, so the C of adverse consequences, the patient is intoxicated all the time or sedated when they're coming and seeing you. They have decreased activity, they're more irritable, increased sleep disturbances, increased pain complaints, increased relationship dysfunction. Or they have impaired control or compulsive use. repeated report or loss of stolen prescription or management, frequent early renewal of prescriptions, urgent calls for unscheduled visits, misuse of other drug and alcohol, withdrawal noted at clinic visits, and observers report overuse or sporadic use. Finally, but not the least, it's the preoccupation with the medication with use due to craving. So its consequences: control, compulsive, and craving. 4 C's. So frequent missed appointments unless opioid renewal is due, and does not try non-opioid treatment, cannot tolerate any medication but opioids, and is very dismissive of specific medication, but also requests specific medication like diazepam or Lyrica or gabapentin. They come up to you saying, well, you know what, this helps me, also prescribe them. There are various ways of identifying opioid risk, opioid analgesic dependence, and these are screening tools, not diagnostic tools, but screening tools. There's a single question screening test, which can identify a person having problem with opioid analgesia, and you should then do a more thorough assessment to establish dependence. Or you could use the ORT, which is opioid risk tool. It is also known as ORAT now, ORAT, which was known as opioid risk assessment tool. SOAP, screen and opioid assessment for patients with pain. Or you can use SISAP, which is the screening instrument for substance abuse potential. So ORAT or ORT can be used as well as SOAP if you want. So what are the areas that you really need to treat when someone comes to you with opioid addiction, opioid analgesic addiction? You just don't kind of stop their opioid analgesia, or you don't just put them on methadone. What is it that you need to treat? These are the components of addiction, or the domains of addiction, and these are the areas that you need to treat: social well-being, substance misuse, physical health, and psychological well-being. You treat all of them together, they overlap, and the patient gets better. So what are the treatment strategies? Well, generally, like with any addiction, to function with drugs, you have to deal with the craving and avoid drugs and handle in relapse prevention. You also need to involve cognitive behavioral informed therapy, which is linked with mindfulness, and you link it up further with stress management that can reduce pain and improve coping. Pharmacological treatment can be used to relieve withdrawal symptoms to help or overcome drug cravings. And there's physical treatment as well. So there are 2 schools of thought. One school of thought is if you're prescribed a medication, for example, codeine, dihydrocodeine, or tramadol, you then prescribe them the same amount and ask them to stop taking it somewhere else, and you're the only one prescribing them. And then you tell them that after 2 weeks, you start reducing the medication very, very gradually in the OPD. By every week, you reduce 1 tablet or something of those lines. The other school of thoughts or evidence-based suggests that you should admit them to a detox unit, put them on replacement opioid therapy like methadone or buprenorphine, and do a proper formal detox, as it is more complex and complicated. So this is from the paper that I mentioned earlier, which was published in 2017, and it looks at various pathways which would be best in terms of management, and you can see how there are a variety of tools that can be used, including adjunctive therapy and supportive therapy on top of medical therapy. No one particular medication is encouraged to be used, but a variety of medication of whatever suits the individual needs. So in summary, it can affect anyone or everyone. Painkillers are not evil medication as long as they're used properly, particularly in long-term use of opioids. So long-term use is not always described as addiction. Addiction means misuse and misappropriation of the prescribed medication. There is a constant review of prescription and the pain. You should try other non-pharmacological methods, like evidence based around CBT for chronic pain is increasing. There's possibility with screening of high-risk patients. There are no properly commissioned service, but some services do offer treatment. In Public Health England and the expert reference group set up by within Public Health England, set up by Matt Hancock, who was the health secretary in the United Kingdom, published a report around addiction medicine. I was part of that expert reference group. it recommends that there should be specific services for opioid analgesic dependence. And the treatment, as I said earlier, could be weaning the medication, stopping, and using lofexidine or using opioid substitute treatment in the inpatient or outpatient, wherever you feel and the patient is comfortable. These are my references if you want to go through them one by one. And there are much more references to what I presented. If you want them, please be in touch. And thank you very much. If you have any questions, please feel free to ask me. I hope that has been useful. And you feel that the knowledge that you've taken away from this presentation helps you in your practice. And just think of one thing will change in your practice after this presentation. Thank you very much and have a good day and enjoy the other presentations. Bye. That's a good question. I was afraid somebody's going to ask this question. So it's absolutely important. Yes, I mentioned functional changes, and there are definitely structural changes as well. Interestingly, the anterior cingulate area, particularly in the dopamine reward pathway, is quite implicated when it comes to having these structural changes. There is, when you're taking opioid, in particular, whether it's painkiller or in any other form of opioid, there is upregulation of receptors. And this upregulation then impairs the functioning of the dopamine reward pathway, which then leads up to reduced uptake of dopamine. Again, I kind of referred this in the presentation as well. But particularly the anterior cingulate area is quite affected and impacted in those who have chronic lifelong heroin problem. But new research has also suggested that those who are have chronic pain and have been on chronic opioids also have similar structural changes. And there is this upregulation of receptors as well as the structural change within the anterior cingulate area, which then eventually affects the dopamine reward pathway. And this effect of the dopamine reward pathway not only makes you more vulnerable and you have more cravings, but also affects the way you experience life. Your ability to experience pleasure is kind of compromised, which then leads up to more psychological morbidities. So again, in short, the answer is yes, it does affect structural changes. Particularly having more upregulation when you're using opioids, hence leading to real intense withdrawal states, and also affecting the anterior cingulate area, compromising the dopamine reward pathway. Thank you.
Thank you very much. We have another question for Dr. Abbasi here. What are the guidelines for the treatment of opioid painkillers and benzodiazepines?
Okay. This talk was mainly about opiate painkillers, but there is an increasing and growing concern about addictions to medicine, prescribed medicines, particularly those which have a potential. So opioid painkillers are one. Then you've got benzodiazepines, which, as I kind of alluded to in the presentation as well, was prescribed in the past, but very clearly we discovered as clinicians that it has very clear abuse potential. And more so now, we're seeing other tablets coming forward, the gabapentinoids, like gabapentin and pregabalin. And one thing I've seen more so over here in the UAE is the misabuse of a tablet called Legaflex or carisoprodol, which again is a centrally acting muscle antispasmodic drug. So a lot of medication which act on the central receptors of the brain, particularly on GABA receptors, have a potential for abuse. So we all need to be really careful. The guidelines, there are guidelines published in Australia. There are some guidelines published in the US, but none of them address it in combination as we generally see in practice. So you have guidelines. I won't go into the details what I mentioned earlier about opioid pain relief medication. You either reduce and gradually taper it off, or you go on to synthetic opioids or morphine equivalent and convert them into morphine. And with benzodiazepine, there's a manual which usually a lot of clinicians refer to in the United Kingdom, was known as Ashton Manual, developed by Professor Ashton at the University of Newcastle. And that was a very slow, gradual withdrawal over a period of weeks, months, and sometimes a year of benzodiazepines. And as I said in the presentation, if it was done, if you're reducing the medication, then you're going in the right direction. There's an element, there's a strong element of trust over here that you feel when you're prescribing some medication to do a taper off at home, the patient is actually complying with it. which is sometimes very difficult to establish. And for those where you find it difficult to establish this trust and you feel there will continuously be a potential for abuse, then you admit them in a clinical setting and do a detoxification within an inpatient setting. So for the opioid, you'd use an opioid relief medication like methadone or buprenorphine. And if you don't have that, then you use symptomatic treatment like lefexidine or other symptomatic treatment for diarrhea, abdominal cramps, vomiting. And for benzodiazepine, there's a role of using anti-epileptic medication and gradual reduction of benzodiazepine alongside it. Naturally, they all have their risks, but within a hospital setting, it is best managed. So if you feel someone who's got opiate, painkiller, and benzodependence, and there are other complexities, I think it's best doing it within a hospital in the way that I've just described. I hope that kind of answered that question. I mean, it's a very wide subject. I can go on talking about it for a long period of time, but we've got limited time, and that is, I think, what we can cover in a nutshell. Thank you.
Yeah, thank you very much. Okay, I have no more questions. I received no more questions from the audience. So thank you very much, Dr. Abbasi. Thanks everyone for joining us for session 2. We will have a break for around 20 minutes, but we will be back at 3:10 p.m. for session number 3. So please come back. And during that time, you can visit the exhibition center. Thank you very much. Have a great day.